be your facilitator today. We have two great presenters with us, and please do write down your question, put them into the chat box. We did take a bunch of your questions from your registration, and Drs. File and DeLucia, I think we'll be able to answer a lot of your questions, but you may still have additional questions that come up during today's presentation, and we will have time to talk, share cases, just figure out what's going on and what's on your minds following the presentation today. So I will have Dr. File introduce himself, and then Dr. DeLucia, and then we'll start sharing the slides.
Well, good afternoon. I'm Tom File from SUMA, and it's a pleasure to be here on ECHO again.
I'm glad to have you.
Yeah, and my name is Angelo DeLucia, and likewise, I'm very happy to share what we've learned since our last time here.
So for those of you, while we're pulling the slides up, who want to collect continuing medical education or continuing education credits for today, the EADS code will be 65SOAP, so 65 Summer Oscar Alpha Patio, and that code expires tomorrow, so use that today. But now I'm going to mute and hand it over to Dr. File.
Well, thank you very much. As Angelo already said, I mean, we've learned a lot in the last 6, 8, 9 months that we've gone through this. I've got a mask on. I don't know if you see me or not, but I am going to take my mask off now because I'm in my office all by myself. But it's really important for us to wear the mask every other time we're certainly within a closed room and other people are in the room. Doesn't matter how far away they are. And I'll talk about that as we go through here. But the only point I want to make with this slide is the bottom, and that is that certainly COVID-19 is the greatest social health and economic threat of our generation, probably of a century for sure. I mean, this has certainly been an unprecedented year. I mean, not only for medicine, but for the entire world. So if I can go to the next slide, I just want to briefly review what I'm going to discuss here, and that is what have we learned?
You watch this with me?
I'm sorry. Hello?
Go ahead, Dr. File. You're good.
Oh, okay. Anyway, I just want to start out with just saying that this has sort of obviously been an unprecedented year, and we've learned a lot, or at least we've experienced a lot of how we've changed our lives, a lot of how we interact, how we do business, and certainly how we care for patients. But I want to point out that the information, even the information we talk about today, changes rapidly. I mean, it may be that we're presenting today could change dramatically within a week or 2 weeks. And that's just how fast this information is accruing. As far as specifically about COVID-19, we've learned a lot about the transmission that has really been relevant of how we try to control it. We've learned a lot about the manifestations over the last several months, therapeutics. I mean, significantly, we've been able to treat patients better than we did 3 or 4 months ago with better outcomes. And then hopefully soon we might have a vaccine. So if I could have the next slide, and we'll go through some of these thoughts more specifically. So as far as transmission, I think I showed this before, but I'm highlighting some additional information. And first of all, we know that the incubation, but the mean is about 5 days, but it can go anywhere from 2 to about 14 days. We do know that SARS-CoV-2 is much more communicable, much more contagious than the endemic coronaviruses. I mean, this is a novel virus, so virtually no one in the world actually was immune to it when it first occurred. I mean, the recent data suggests that maybe 10% of the world has been exposed to this, or at least become immune. So still 90% of us are still susceptible. It's much more contagious even than influenza. And I'll be talking about this towards the end because we're concerned about co-infection with influenza as well. If you look at the reproducibility score, that is, if I've got COVID, how many people may I tend to infect? Well, it's anywhere from about 2 to 4, but to put that in perspective, for influenza, it's about 1. So this is more communicable, more transmissible. We also now know that it's highly transmissible from 2 to 3 days before symptoms. And if you go down to the bottom of this slide, we also know that it's transmissible from patients who never develop symptoms. And the problem is that in some studies, as much as 40 to 50% of the patients who are infected with this virus never develop symptoms. And I'm showing you a pyramid here. This is just a study where from a cruise ship. It was done earlier this year, looking at the positive rate of patients, or in this case, cruise passengers or the crew of the cruise who were positive, but yet never developed symptoms, which was the majority of the persons who were tested. So this is going to be a significant issue. It makes it much more difficult for us to contain this type of infection. To give you some perspective, with SARS, that was in 2003, that virus was not transmissible until patients were sick. So you could easily stop the transmission by quarantining people who are sick. In this case, however, since people who are transmitted who are not sick, it's very difficult. We literally have to assume that essentially anybody or everybody could be affected with this and therefore potentially transmitted. I've also got in bold the role of airborne, and I'm going to talk about that in just a second. So could I have the next slide? And this is a recent slide that just came out, I guess about 2 or 3 weeks ago from CDC, that looks at our present information as far as what samples or what part of our body, I guess if you want to call it that, can transmit the infection. And so basically right now, it's just transmitted from respiratory samples, at least from acute patient to patient contact. You can see that respiratory samples definitely have been observed to be associated with transmission. However, we have seen where stool, bloods, or serum, you can identify the virus, but there's been, as of yet anyway, no observed mode of transmission. And then there's other specimens there, such as semen and urine, which is not been found to be associated with transmission at all. So could I have the next slide? In fact, I'm trying to make sure we go through questions. There were a lot of questions that came in about aerosols. And so I want to comment a little bit about this. On the left-hand part of this slide is an image that was accompanying a letter that was published in July from a variety of aerosol physicists. They weren't clinicians, but physicists that really were trying to state that, you know, really we should be concerned about airborne, not just the respiratory droplets. And their point was that as patients speak or they cough or they sneeze, not only do you have this 6-foot respiratory droplet, which are larger droplets which tend to fall to surfaces or the floor within 6 feet, you've got these smaller particles. Some of these are small droplets which may even dry quickly within air currents and then can be suspended in air for minutes and even hours. One of the questions is, how long can these droplets stay? Well, the small droplets or particles can stay suspended in a room, particularly if there's low ventilation, for a few hours. And that's important when we talk about the importance of wearing a mask in an enclosed space. It's, you know, just being 6 feet away with these potential for aerosols is not going to be absolutely protective. You should still wear a mask inside. There's also one of the questions about fomites. Well, we do know that the virus can stay viable on surfaces, whether it's a doorknob or a keypad or whatever, for hours. Studies have shown that you can detect the nucleic acid for days, but probably infectiousness or transmissibility is only about 2 or 3 hours. But still, it's important to disinfect surfaces after people have used them. Next slide, please. What about clinical characteristics? And I'm going relatively rapidly because I want to have a lot of time here for questions. But, you know, initially when we talked about this several months ago, we talked about, you know, patients who were sick enough to come in the hospital, and it was basically a triad of symptoms. That was fever, cough, and shortness of breath, or dyspnea, as I have listed here. But now, as we've seen patients who are less ill, and particularly patients who are evaluated in an ambulatory setting, we've become aware of a whole cluster, a whole spectrum of symptoms, such as chills, repeated chills, muscle pain, myalgias, headaches, sore throat, new loss of taste or smell, which is becoming more and more significantly associated with COVID. I mean, that particular symptom, particularly loss of smell, can be seen with any respiratory virus, but it seems to be somewhat higher associated with COVID-19. At least in our experience, if you really ask a patient about potential loss of smell, about 30 or 40% of our patients have experienced this. And quite honestly, it may even be the only symptom they have. Patients can also have GI symptoms, initially upper GI, such as anorexia or vomiting. Later in the course, more lower GI symptoms, such as diarrhea. And then there's even a variety of rashes that have been associated with COVID-19. So there's a whole spectrum of the symptoms now of which we're aware that could be potentially associated with this virus. But I've already mentioned that a high percentage of patients can have asymptomatic infection and potentially spread this. As far as associated labs, like some other viral infections, we often see lymphopenia, elevated liver function tests, LDH elevated because of the component of LDH from lungs. Oftentimes the creatinine would be elevated mainly because of dehydration. And then we see oftentimes later in the course of an infection, an elevated inflammatory markers that I have listed here: C-reactive protein, D-dimers, troponin, ferritin, etc. And these are important for us to follow because they may portend an inflammatory or immune reaction that may lead to significant increased symptoms, particularly in patients who are sick enough to come in the hospital. So if you look at the last bullet point now, we now know that most patients, they're either asymptomatic or have mild infection, and I'm talking about 80% of patients. But a lot of those mild infections who don't have to come in the hospital still don't feel very well. I mean, it's like a bad case of the flu. But for patients that come into the hospital, particularly, we're concerned about a potential for a biphasic illness. In other words, initially they may have the fever and the chills and the cough. That may respond a bit, particularly if we use some of the antiviral agents that are now available to us. But that may be followed by a second stage, or the so-called immune inflammatory stage, where it's almost an exaggerated response of the immune system that can lead to damage to multiple organs. So could I have the next slide? And I'm going to show you this subsequently. But, you know, initially we considered this primarily just a respiratory infection. I mean, certainly that is the mode of entry of the virus into patients, that is through the respiratory tract. However, we know that when patients are infected with this, very commonly, particularly in patients who are sick enough to come to the hospital, other organs are involved. And if you look at the left-hand part of the slide, the heart, the brain, kidney, liver, coagulation abnormalities, even cutaneous manifestations. I mentioned potential for rashes. And a lot of this is due to the mechanisms on the right-hand side, which could be direct viral infection. I mean, not only the lungs, but the heart has been shown to be infected directly with the virus. The brain has been shown to be directly infected with the virus. So that can be a mechanism by which these other organs are involved. It could be because hypoxemia of the organs, if the patient has significant hypoxia because of lung involvement. And that's one of the issues of concern with COVID-19, is that you can have diffuse pulmonary infiltrates related to the infection in the lung that may lead to hypoxemia that causes disruption of the function of other organs. There's coagulopathy. You can get blood clots. I mean, it's not uncommon for patients to have blood clots in the coronary arteries, the cerebral arteries, and come in with strokes. And then, as I've already mentioned, there's this inflammatory response, which is almost an exaggerated response of the immune system, the so-called cytokine storm, if you will. And we'll measure some of these cytokines in patients, particularly in the hospital, because we hope that as we treat patients, those markers of inflammation will drop, certainly before they leave the hospital. Now, talking about that, going back to the left-hand part of this slide, I have the multiple inflammatory syndrome in children. You know, it was initially described as a Kawasaki's-like illness. I think it's a little bit different than that, but this is an exaggerated immune response by the patients. And when you look at the cluster of all these patients, there have been hundreds of these described now in the United States, where patients all of a sudden would present with multi-system inflammatory disorder. They would not have evidence of COVID tests positive by virtue of the PCR test, but what they would have is positive antibody tests suggesting that they were exposed or infected earlier, and now in its immune reaction to the virus. And I can tell you just earlier this week now, there's now an MIS-A syndrome, and the A stands for adults. So this multiple inflammatory syndrome now has been described in adults as well. And then there's the mental health issue. Even if you don't have significant organ involvement, there's a lot of depression, a lot of anxiety that's been associated with this, even in patients who have not been truly infected with this, but they're concerned about it. And there's a lot of fear about the concern for infection. So next slide. So, you know, when we see new infections like this, when we see pandemics, there's a tendency to want to look in the literature and see if there's any rationale for therapeutics that might be beneficial, even though we have no proven evidence of efficacy. And this certainly has been the case with this infection. I'm showing on the left-hand part of the slide that first bullet point about early attempted treatments. There was use of influenza medications, use of HIV medications to see, because these are all caused by viruses, to see if they would have effect on this virus. And of course, the famous one or infamous one is the hydroxychloroquine with or without azithromycin. And I'm showing you on the right-hand part of the slide a chart that came from a study, very small study, many limitations and flaws in the study, but it was used to justify the use of hydroxychloroquine with or without aztreonam. Because if you look at that part of the graph that goes down dramatically towards zero, it suggested that the combination of hydroxychloroquine and azithromycin was very effective in reducing the virus within a patient. However, there's a lot of flaws with this study, and subsequently multiple well-controlled randomized trials have not shown any benefit with hydroxychloroquine, whereas early in the epidemic, many of us used it because we thought it might have some benefit. None of us use it. Well, most of us don't use it anymore because we just don't have the evidence of any efficacy. However, if you look in the bolded part on the left-hand part of this slide, I'm showing you two interventions which have been shown to be beneficial on the basis of randomized clinical trials, so true evidence. And one is the antiviral medication remdesivir, which has definitely been shown to reduce the duration of illness. And there's a trend towards reducing mortality. It didn't quite reach statistical significance. I think it was like 0.07, but there's a trend there for reducing mortality, but definitely showed it reduced duration of illness. And then dexamethasone, which quite honestly did, at least in patients who were sick enough to be in the hospital and on supplemental oxygen, definitely showed to reduce mortality. So these two interventions we're using quite a bit, and I can tell you in our own experience has significantly led to improved outcomes for our patients. But I think the bottom line here is that we need to treat based on scientific evidence, not just on opinion. Next slide. Yeah, thanks. And so this is our overall concept of how we manage patients now. If you look on the top, you can see the two stages. The viral stage, that's where the patients are initially infected. They may have the symptoms of the cough and the fever, etc. And this is where we really don't, you know, if you look at the asymptomatic phase, in that bar in the middle, I'm showing you the spectrum of illness, which goes from asymptomatic or pre-symptomatic phase to the right-hand side, critical illness, potentially even death. And of course, in the middle, there's the mild, moderate, and severe. And I just want to sort of review our definition of moderate illness and severe illness, because this is important how we classify patients. And this is important, you know, how there was a lot of reaction to how the president was treated. But if patients come in the hospital and they don't require oxygen saturation, such that their oxygen saturation is a greater than 94%, then generally we consider that moderate illness. However, if the oxygen saturation drops and they require oxygen supplementation, then we consider that severe. And then critical means that they're usually in the ICU and require mechanical ventilation. So this is how we treat patients. And so we know actually that for moderate illness, severe illness, and critical illness, we like to treat early with the antiviral medicine. Actually, the data supports the use of remdesivir in patients who require oxygen supplementation. I've got that bar on the bottom that goes all the way over to moderate because the FDA did allow emergency use authorization for even early COVID-19 who are in the hospital. Early in the course of the patient, this is where we might consider antibody therapy, such as convalescent plasma, or even the monoclonal antibodies that you've heard about, again, because of the treatment of the president. But this is where you want to treat relatively early in the viral phase, because the rationale here is for the antibodies to neutralize the virus early to reduce the effect on various organs. And then for severe illness, this is where, or critical illness, this is where we're talking about the anti-inflammatory agents such as steroids, where it has been shown to be of benefit. Now, because patients particularly coming to the hospital seem to be hypercoagulable, most of these patients are at least getting preventative anticoagulation therapy. Next slide. And so just quickly, I want to show you over the last several months, two guidelines that have very systematically looked at all the evidence for how we can intervene to benefit our patients. The first is from the Infectious Disease Society of America, which is a very high level. GRADE is just a way of systemically evaluating and grading the evidence. And then the NIH is the National Institutes of Health, which is a consensus guideline. But and on the left-hand column, you can see I've got three of the interventions highlighted, and those are convalescent plasma, remdesivir, which is the antiviral, and dexamethasone, which is the steroid, because these are the three for which FDA has issued a emergency use authorization. Having said that, however, only remdesivir and dexamethasone have been shown in randomized clinical trials to be of benefit. There's some other sort of interventions that are tried. The IL-6 inhibitors, right now, the studies have not shown the benefit so far. So you can see that the recommendation is against routine use, particularly for IDSA. They specifically recommend tocilizumab, mainly because the randomized clinical trials have not shown a benefit so far. Some observational studies have. Vitamin C, vitamin D, zinc, and famotidine. Again, I'm just putting that in there, but because of the use you may have heard about recently, but nevertheless, again, there's just not robust evidence at all of benefit. Now with vitamin D, you're probably aware that that is important overall in our immune function. So if patients are deficient in vitamin D, they tend to not do as well than if they are normal in vitamin D. And of course, we're concerned about that in cloudy northern Ohio here. Next slide, please. And then as far as one of the concerns now we're beginning to learn about is when patients recover from their acute illness, they may have these lingering symptoms. And it was first evaluated in Rome in a study of these 143 patients where patients were seen about 2-3 months later, and still most of them had some type of symptoms. 44% said that their quality of life was still worse. And I think of great concern is these studies showing that even patients who are asymptomatic but infected, and you might ask, well, how do we know they were infected if they're asymptomatic? Well, these were patients who were either identified because of contact tracing, because they had exposure to somebody who was positive, and then they tested positive but never had symptoms, or they were some of these congregate settings like the cruise ships, like I just mentioned earlier. And some of these have been evaluated with imaging studies of the lung, imaging studies, MRI studies of the heart, and finding abnormal findings suggestive of damage. Now, a lot of these patients are young, probably don't have significant symptoms or any symptoms by definition, since they're asymptomatic, but who knows what's going to happen over a period of time. So this is something we have to follow and see if these effects remain persistent and cause problems as years go or accumulate. Next slide. And then there's a question about, well, how long are patients infectious? Well, there's good data now to show that when patients are symptomatic, unless they're severely immunocompromised, like a transplant patient or a patient who is on chemotherapy or whatever, that after 10 days from their start of symptoms, they are no longer contagious or infectious. Now, that's different than being able to identify nucleic acid in the PCR test, because often these patients will shed nucleic acid segments for weeks or months, but that does not mean that they're infectious. In general, when we see a patient and we send them home, we consider taking them out of quarantine 10 days after the onset of their symptoms. Next slide. And then as far as control, initially we tried to contain this virus by stopping people coming in from other areas of the world like China. Obviously that did not contain it. So then once it became transmissible within this country, we started going to mitigation control, which meant, physical distancing, avoiding gatherings, not avoiding masks, obviously wearing the masks, hand hygiene and disinfection. And next slide. I just want to use this because we did have an echo on the use of masks, if you remember a couple months ago. On the left-hand part of the slide is a meta-analysis that looked at the benefit of masks. Now, most of these masks were either N95s or surgical masks, not necessarily a cloth mask. And it looked at the transmission of the coronavirus, not only COVID-19, but also SARS and MERS, and found, if you look at and I've got the segment of this forest plot enlarged to show that the face masks did prevent transmission of the virus. And there's also additional information that cloth masks as well are beneficial. And I want to call your attention to the right-hand part of the slide of this illustration, which shows the benefit of masks and distances. So if you look at the top two people, if the third or the person on the left is infected, but neither one of them, and the person on the right is not, but if they neither have a mask, the infectivity of that person to the right within 6 feet is very high. If you go down to the fourth dual image, where they're both wearing masks, even though they're within 6 feet, it's relatively low. And if you go to the second or the next one, which is greater than 6 feet, and they're both wearing masks, it's very low. But I think this is very important now with the understanding and appreciation that there can be some airborne aerosolized spread, particularly in an enclosed area with low ventilation. So to me, the message is that when you're inside, even if you're 10, 20 feet apart from somebody, still wear the mask, because you could be shedding small particles that could be infecting others that are maybe 10 or 20 feet away. Next slide. And then finally, is the vaccine, and I think Angelo's going to talk about this, but there's two of these candidates. The first two columns, Moderna's and Pfizer's, are in their late stage. They both completed enrollment. They're waiting for at least 2 months of exposure to get safety, and then hopefully we'll have efficacy by then. And we can talk about this later, but I'm hopeful that at least one of these or both of these will be very effective and show good efficacy, and then this will allow us to start to contain this epidemic pandemic, because not only will it hopefully prevent infection, it should prevent transmission by virtue of having a herd immunity. And then the next slide just talks about If I can go to the next slide. We still don't know what's going to happen with the fall or the winter surge, the effect of co-infection with the influenza. We're certainly hoping that the vaccines will be effective. We don't know about the immunity or the duration of immunity. I know there were several questions about that. What are going to be the long-term clinical effects of some of these manifestations that we've talked about? What is the long-term viral presence? Is this going to have outbreaks of COVID-19, and how often will we have to be immunized? What is the correlation of the viral load and clinical manifestations and the level of cytokines associated with mortality? So there's still a lot that we need to learn that are going to help us in the future to contain this pandemic. And I think I'll stop here. I think there's another slide on influenza, but we can discuss that maybe because I don't want to go over Angelo's time. So I'll turn it over to Angelo, Dr. DeLucia.
Well, thanks very much, Tom. It was great. Very nice summary of things that have been occurring since the last time that we were here. Could I have the next slide, please? Okay, so I'm going to go back. I want to introduce this a little bit. I'm going to focus mainly on the vaccine and what we know about it, when it's going to maybe appear, and particularly focus on efficacy and safety, of course. But before I get started, there's one thing. Well, there's a couple things here that I'm trying to emphasize is that public health is a critical component to building the trust necessary for the idea that we all need to be vaccinated. And so that's why I'm very pleased to be able to talk to you about this. And I would like to say one thing that's good news is that the World Health Organization has just announced that all wild type poliovirus has been extinct in Africa for the first time. And so that is due to the efforts of public health, vaccination in very difficult places, war-torn areas, whatever. They've managed through the efforts of people very extraordinarily dedicated like yourself to basically eliminate wild type polio and poliomyelitis in the African continent. So I think you deserve, and the people that you're associated with deserve great praise. So next slide, please. So I'm not an immunologist, and the immunology of this virus infection is extraordinarily complex. So I'd like to first briefly just talk about a basic primer on a virus infection and the immune response that is in general, it happens to all infectious viruses that humans can get. So the key understanding of this is that we'll be looking at, or you'll be hearing about, a number of things in the news that we'll be talking about some of the things I'm going to be mentioning, and you'll be well primed or prepared, hopefully, for further understanding. So we've previously talked about how the virus interacts with the host cell in our bodies through the angiotensin converting enzyme AC2 receptor, which is present on a number of different cell types. And then that is brought into the cell, the virus is brought into the cell and infects the cell and makes thousands of copies of itself, and sometimes obviously kills the cell, but for the most part goes on to infect other nearby cells. And if unabated, that can cause all of those problems that Dr. File just talked about in detail. Okay, so all of the organs are affected, and particularly, for example, the lungs. And you see, when you affect the lungs and you affect the brain, you affect the heart, you get acute effects very quickly. But in any case, our body has evolved to recognize these foreign invaders and of course try to deal with them. And that is done by two huge armaments that we have to fight off viral infections. And that is, when the virus appears, we have cells that will recognize this virus, what we call epitopes, or various markers that can be recognized by endogenous cells. They actually then degrade those and present peptides to T cells. The first, we call them T helper cells. And then those T helper cells basically get the body geared up to fight off the virus by inducing cytotoxic T cells, which will actually go and surveil and kill cells that have been infected with the virus. And then also they will enhance B cells to start producing, differentiate and become plasma B cells, which will actually generate specific antibodies against the incoming virus. And now B cells are activated by T helper cells, but B cells also can, in fact, recognize virus antigens on their own. And so there's another route that's not shown here, but a B cell can actually recognize the virus and, in fact, then go on to produce very specific antibodies that will hopefully coat the virus. And this is what we refer to as neutralization. Antibodies that will recognize viral proteins and then coat the virus so that, in fact, the virus will no longer be able to infect uninfected cells in our body. And if they do that in a very efficient manner, then it's called neutralizing system or neutralizing antibodies. And so all of our vaccines presently being generated will, in fact, mainly go down this route, which they're trying to induce B cells that will produce specific antibodies that will prevent viral infection from occurring in our bodies, even in the presence of virus. And so more sophisticated vaccines will, in fact, in the future, if we find out that we need even greater help, more sophisticated vaccines could, in fact, be developed or being thought to be developed that could, in fact, induce so-called T cell or cytotoxic T cells that will kill virus-infected cells. So our natural immunity, we have this going, but in our vaccinated population, we will mainly have only this armament to fight off the virus. But right now, there are a number of good studies that I'm going to be talking about that have indicated that this route is sufficient. Okay, so there's a rhesus macaque monkey model that they can be infected with the SARS-CoV-2, and they don't show all of the symptoms that Dr. Feil just talked about, but they do get mild respiratory tract, and they do get potentially even interstitial signs of interstitial pneumonia, and of course none of them die. But in any case, they show very well infections that are due to SARS-CoV-2 that mimic what's happening in human beings. We can vaccinate them with the vaccines that we're going to be showing shortly, and in fact, then challenge these vaccinated macaques with wild-type virus, and the macaques have warded off virus infection. They do not get these symptoms. They do not get any signs of lung involvement, and so those studies have indicated very nicely that the current phase 3 studies are, in fact, very worthwhile and, in fact, will be effective at warding off virus in humans. And so that, of course, we need to do the experiment in humans, which is vaccinating these 30,000 people in a number of studies, and then seeing what is the effect of the vaccine in warding off virus. Now, we can't do the challenge experiments, and we're not going to do those as far as I'm aware of, which is good because this virus is so potentially deadly. So next slide, please. So again, going back to the public health message that I'd like to convey. As scientists now, we're witnessing these ongoing phase 3 trials, and praise in the sophisticated and innovative technologies needs to be replaced by actions and messages that will foster trust among clinicians and the public. So this means radical transparency by the companies and the academic individuals that are associated with these vaccine trials and design. And so far, 9 CEOs of pharmaceutical companies have, in fact, pledged to show data and information that they have never ever shown before. And so that's good that we have that pledge. And we also, 3 trials have shown their protocols enrollment of individuals, the race, gender, age, all of those things have now available for us to view. And so that also is extraordinarily good. And we hope for more of that when we see the actual results of the phase 3 trials, the various concerns that for side effects, the various efficacy will be available for even people that are not involved in the vaccine trials. So we have 3 concerns in general, right? When will we have confidence that the available vaccines are safe and effective? What do we mean by safe and effective? When will such vaccines be available to the general population? And when will vaccine uptake be high enough for us to return to normal? And the next slide. Okay, so this is just a summary of like what's happened in the past and what's happening currently. And in the past, we have, in general, all of us have probably been exposed to 4 coronaviruses that are circulating amongst all of us in the world, and they are restricted to the upper respiratory tract, and they cause the common cold, or 30% or 40% of all common colds are caused by these 4 viruses, and we probably could be reinfected when it's not clear the immunology of these, and the study of these is not very well known, because basically, let's face it, they don't cause much other than a cold, and there's not much money and there's not much scientific interest, although there potentially should be, but there's not much interest in studying these, at least in the past, and so therefore that's what we had before. Then in 2002 and 2003, we had the emergence of the first SARS virus, SARS-CoV-1, and this was a striking infection. It was difficult to understand because, hey, it was a member of the coronaviruses that caused cold, but it caused death in a certain number of individuals. And the difference between what we have facing now, Dr. Feil mentioned the thing that we're facing now, which is potentially in 100 years, certainly one of the most serious pandemics, is that the first SARS-CoV-1 was mainly restricted to the lower respiratory tract, and found it could cause havoc and cause death, but it was not really that highly transmissible compared to the SARS-CoV-2. Now, you did have the concept. Dr. Feil talked about R naught. Okay, so how many individuals that are infected could potentially pass that off? And that's an average of certainly between 2, 3 or so for SARS-CoV-2. And that's an important concept, but potentially what's happening on the horizon right, which is new, is sort of like this new K value, dispersion rate. And that was fairly low, obviously extraordinarily low for SARS-CoV-1, but it seems to be relatively high for SARS-CoV-2. What does that mean? That means that we found in the previous epidemic that we had certain individuals, so-called super spreaders. There was an individual that got on a plane from Taiwan, and basically at the end of the trip, the entire population of the plane was infected. But otherwise, many of those people did not go on to infect other individuals. And so we're seeing there's a controversy with SARS-CoV-2. Do we have that or don't we? And there seems to be the data is still not clear, but there definitely seems to be some idea of super spreaders in SARS-CoV-2. These individuals can in fact be more infectious than others, and so we need to be on the lookout for more data in regard to that, in terms of what is potentially causing that. First of all, does it exist? Does a super spreader, do they really exist, and then how frequent is that? So that's something that you need to be on the lookout. We go to the next slide. So typically showing that the typical development has taken a number of years. Okay, so this is 28 years for flu mist, 28 years, and the human papillomaviruses, which I've been associated with, it took at least 15 years and quite a few number of years at the beginning for Dr. Zerhausen to sort of convince the scientific establishment, plus also a number of pharmaceutical companies, that it would be worthwhile to develop a vaccine against human papillomaviruses and thereby prevent cervical cancer, which we're seeing. Similarly with rotaviruses. Now, I'd like to just inject a couple things here. Although I'm obviously, I'm very pro-vaccine. I have had to directly suffer from measles, mumps, and chickenpox myself, and I've seen where my children didn't have to suffer those diseases by being vaccinated. So I'm extraordinarily pro-vaccine. But there are some previous things that that you may hear about, particularly when people are potentially resisting vaccination, that are potentially serious. So, for example, the very first rotavirus vaccine had to be withdrawn because it was not necessarily tested in large enough populations to show intussusception when it was delivered to a number of individuals later on in greater numbers. So that vaccine was removed, but then subsequently 2 new vaccines have been tested at greater numbers and are extraordinarily safe. And so we learned a lot from that event. And secondly, dengue virus vaccine has caused some disruption in particularly, you may have heard, in the Philippines, but there are definitely different. I mean, there are reasons for that, in that dengue has 4 different serotypes, and the vaccine didn't necessarily control those serotypes to the extent that we thought available. Now, the good news for us with SARS-CoV-2 is that although mutations are occurring in the virus, they do not seem to be escape mutations as of yet. We do not find them in great numbers that we did find in, for example, influenza virus. We find a large number of escape mutations there. And that's why we have to vaccinate every year. We do not find them so far. Obviously, the virus is mutating. So far, mutations in the receptor binding domain is one of the key places where the virus interacts with AC2. Those mutations are not occurring to a great degree. So our neutralizing antibodies that I talked about before are mainly focusing on blocking the viral receptor binding domain, okay, and that spike protein that we talked about previously, from engaging or interacting with the AC2 receptor. So that's very good news, okay? So in terms of viral mutants not escaping vaccines that we're going to be delivering. However, what isn't known, and what will have to be known, is the duration of the immune correlates of protection. So the immune correlates of protection are antibody titer, the levels of antibodies that occur, and how long they stay around. Okay, so, and then also, if for people that are naturally infected, the T cell response, and how long does the T cells, the memory T cells, hang out, and how long do they stay active? Okay, so that you can have potentially ward off reinfection. And now we know that there are a couple of reinfections, very well documented reinfections cases. Those are still being studied as to how that happened and why, and we still need greater numbers of those in order to figure out exactly what is happening in there in terms of reinfection possibilities. We do know, though, that antibodies alone, if we go back to human papillomaviruses, the vaccine there just generates neutralizing antibodies, and they hang out for a very long time, or the memory B cells that can generate them potentially hang out for a very long time. And so therefore, those individuals are very well protected for a very long period of time, up to several years after vaccination. So the hope is, though, that we will immediately generate high antibody titers that will neutralize infectious virus. And we also generate memory B cells that, even if the viral antibody titers go down, that these memory B cells will hang out, and then they will be quickly activated upon incoming virus. And so that is the current hope, that only time will tell whether that really happens or not. So go to the next slide, please. So these are the different platforms that are being developed. And I'd just like to briefly mention what Dr. File was focusing on, where they're completing their phase 3 studies. They're using mainly what's called an RNA platform, or RNA based. So it's RNA from the that codes for the viral spike protein, and then that's packaged in a lipid, and that's injected, and then eventually picked up by cells. Cells will take that up, and they will express the RNA and produce spike protein, which will be recognized by our immune system, and antibodies against that will be readily generated. And we do know, we have very high faith that this will work, because the macaque study that I mentioned was used DNA based platforms that had the S protein encoded in the DNA, and that was injected into these rhesus monkeys, rhesus macaques, which then were defeated challenge upon wild type virus later on. And so we have great hope that these routes of and developments will in fact ward off wild type SARS-CoV-2. Again, the re-challenge was like basically after essentially a month after vaccination. And then I haven't seen the best data. I haven't seen most recent data. They're going to, of course, re-challenge these again later on. And I haven't seen that data yet, in terms of like, okay, so if we challenge these macaques again, can they ward off wild type virus? And that's coming, but I don't know what that data is. And the next slide. So this is just showing briefly what potentially is happening. When we have a very high titer of virus, but approximately 5 days post-exposure, and immediately, in basically 100% of all cases that we've examined, we have an immediate response. And so that's the good news, is that even individuals that are eventually going to get sick, they develop an antibody response against the virus. And with the development of antibodies against the virus, the viral RNA does come down, so that basically, essentially, by day 21, you're no longer infectious, as Dr. File talked about, and also we can barely detect any virus present even using PCR. And in a normal case, with a resolving case, we see that this level of antibody hangs in there for a while, and then it's completely unknown. There are people that suggest, well, a month out, it goes away, but there are other people that say, no, we're able to detect antibodies actually several months now after infection. And then with SARS-CoV-1, we've had some healthcare workers infected, and we've found that basically several years later, we still find IgG in those people. And this is like maybe 10 years later. But in fact, whether that would be neutralizing or not is completely unknown. So we can't count on those studies as indicating protection far out. And as Dr. File mentioned, that may mean that we may need booster shots, for example, to reactivate our memory B cells, so that we get neutralizing antibody up to levels that will in fact prevent infection. Now, there is one complication here. In people that become critically ill, they have a very high titer of antibodies and neutralizing antibodies against the virus. And so it seems that, and also, of course, they have what we call dysregulated immune response. They have extraordinarily high cytokines, and potentially, even despite neutralizing incoming virus, they cannot suffer from the cytokine levels and cytokine storm that Dr. File talked about. And so therefore they're thrown into this, critically ill stage of patient care. And so that is an issue, but this is mainly dysregulation of the immune system. So our vaccines will definitely not be part of that, we will not be concerned with dysregulation of the immune system when we vaccinate uninfected individuals. The final thing I'd like to talk about is that you will be hearing about potential concerns about the vaccine with antibody-dependent enhancement, ADE. And so far in our model systems, the macaques again, and rats and humanized mice, that is not a problem, okay? So the presence of antibodies, the idea is that the presence of antibodies actually enhance, because of this pattern over here, the presence of antibodies enhance the viral infection. So far, we have not seen that. It is not a major concern in this virus infection, although it is, for going back to dengue virus, it is a problem there. It is not seen to be a problem here in SARS-CoV-2. And so of course, we will know more later on, but that is one thing that you may hear objections about. So far, the studies look very good. That's not a problem. So I think that's our final slide. This is just some of the key questions. I'm not going to have time to go over them, but these are some of the key questions that scientists and immunologists and other individuals associated with this whole process are concerned with. And so we're asking these questions with the intent of, in fact, answering every one of them in some detail.
So thank you very much, Dr. DeLucia and Dr. File, for a very comprehensive overview. We had a couple questions come in through the chat, and if you have the ability to stay on a little bit longer than 1 p.m., we certainly invite anybody to do that who's able. So one of the questions is, when you talk about the use of mask, what is the baseline particle size and the velocity of the spectrum, coughing or just talking?
Well, this is Tom. I mean, I'm not a aerosolized physiologist or whatever. And when you look, actually, what I would do is refer the questioner to the CDC website, where they just posted on Monday their updated guidance of how to assess respiratory droplets versus aerosolized airborne particles. And the point that they're making is, don't think of them as two separate entities. It's really a continuum of larger particles and then smaller particles. And all we know is that the smaller particles can be suspended for a longer period of time and go further distance than the larger particles. I mean, some people differentiate 5 microns versus less than 5 microns. But when you read that guidance, it talks about, the sort of the perception of airborne transmission from a public health standpoint is different than how physiologists view aerosols. And from our standpoint, all we can say is that with this particular infection, it's more transmissible, could probably be more released from somebody talking like I am right now, fairly loud. And I'm probably releasing both large droplets as well as small particles. And the more you cough, the more you sneeze, the more you sing loudly, the more you're going to disperse these. The message is, the farther away you are, the better. And wearing a mask, particularly inside and particularly in an enclosed space, is very important.
So we have 2 additional questions. One is, does blood type make a difference in your chance of getting the virus?
Yeah, so I can address that. Yeah, I can address that. There's 2 studies actually that have looked at that, rather large, in 2,000, over 2,000 actually COVID patients. And they've found that blood group A is actually the most infectious, and blood group O has the least association, or at least infection out of those people, least number of infected. That's been done by 2 studies, but the significance of that is still, from my views, is unclear. But those are the numbers. Okay.
Thank you. Are the mental health symptoms believed to be associated with the emotional, mental, and spiritual response to the illness, or the associated, or are they more associated with some type of biologic factor of the virus?
So again, I have being a member of the COVID task force from Case and Cleveland Clinic, there are people looking into that. There's some veterans, for example, that clearly have neurological deficits that are organic, that in terms of what they've the treating physician. And I have a colleague who's working on this, and so there are definite effects. I don't know if you call them direct effects, but there are definite effects of the virus in brain function. And then, of course, overlaying that, obviously, the enormous other considerations that we have of dealing with this that are way outside my expertise. But let me reiterate: there are definite deficits directly due to the presence of the virus, and then you have overlaid on top of that these enormous other problems that we have other experts that know what they're talking about.
Yeah, well, in addition to the sort of the emotional or the depression, I mean, there's definitely neurocognitive issues that are related to this. Now, whether that's like Angelo said, whether that's related to direct effect of the virus or secondary effects, I don't know, but there's a lot of concern about that.
Absolutely. Do you have comments on BCG?
No.
Yeah, not really. I mean, I've seen it, people talking about it, but I haven't seen enough data that convinces anyone that says, oh yeah, we have to run around now, do that, and do and suddenly do it.
And any suggestions for individuals who are exercising indoors, for example, going to a group exercise class that is spaced 6 feet apart?
Well, they definitely need to wear masks and try to be as spaced apart as much as possible. When you're exercising, you're going to be liberating a lot of potential infectious particles. And remember, you may feel healthy, but you still could be infected. So you've got to wear that mask.
Absolutely. Will people be tested for antibodies before getting a vaccine?
I doubt it. That's all I can say.
I would say that only if the that would be of concern only if there are more studies on this antibody dependent enhancement, which I doubt. I mean, so for example, I right now at the moment I would agree with Tom, and I don't think that's going to be in at least the 3 protocols. I haven't seen that in those 3 protocols.
Okay. Any new information on children and the virus?
Well, the only thing I'll say about that, other than the multiple system or multiple inflammatory syndrome, is that there's a bunch of studies, concerned about what is the potential infectiousness of children. And it looks like the younger children under the age of 10, maybe because, Dr. DeLucia talked about the ACE2 receptors. They seem to be somewhat less mature or less developed in the younger age group. And they don't seem to be as infected as much and don't seem to be transmissible as much as children over 10. Now, once you get over 10, it's just like an adult as far as transmissibility. So I think you really have to consider what's a child and what age group you're thinking about.
Yeah, very good distinction. Do we know yet if people will develop immunity after exposure? And if they do, for how long?
Well, they do, but we don't know for how long yet, because I mean, we just haven't had the ability to follow these patients for an extended period of time. I mean, there's even been a few case reports of reinfection already after several months. So we're just going to have to follow that.
Another question that just came in: will COVID become seasonal illness like the flu, or do we think that there will be a vaccine to suppress it like we have with polio?
Well, that was one of the questions I had on my last slide. Is it going to do that, or is it going to transition to be like one of the endemic coronaviruses that cause minor upper respiratory tract infections, or is it going to become like influenza, where it'll be a seasonal associated with potentially serious infections that we need to be continually receiving a vaccine? We don't know how that's going to transition.
Yeah, some indicators are that, as I mentioned, mutation rate is present, but not high enough maybe for that to happen. However, if it could hide in animals, for example, like go back to bats and hang out and then reappear at some time later. Those are theoretical, but also practical considerations. So the virus being able to mutate and escape the vaccine so far is not high on the list of concerns, although theoretically possible. But the virus hiding out and then reappearing later on, if we find durability of immunity not very high, that's a higher on the list of theoretical considerations. But in terms of it's sort of like reappearing every year or whatever, we just don't know.
Thank you. What are your thoughts on being indoors but having an open door or window, so having some fresh air ventilation?
Well, ventilation is good. Closed in enclosed spaces without ventilation is bad. So I'll say that's why, there's this perception that, if you're more than 6 feet apart, you don't have to wear a mask. Well, if you're in a closed space without ventilation, that's absolutely false. You need to wear a mask. And I don't care if you're 20 or 25 feet apart.
It's a very good point. I guess the last question, unless a couple others come in, does any country have a reliable vaccine yet from what you understand?
The Indians, India has a tremendous vaccine production capability. They are engaged in some of these developments that they didn't really have time to get into, and they will potentially be producing these for their country, and also, of course, others across the globe. Within a certain amount of time. Lets me explain. Dr. Fauci has recently looked at much of the vaccine data in great detail, and has suggested in public that at the end of the year we'll have 20 to 30 million people being injected with vaccine, or have vaccine, and in the doses required, which potentially could be 2 doses for some of them, maybe 1 dose, depending on if you're getting a different vaccine, if you're getting the AstraZeneca. And so that's a pretty good idea of when will we have it. And again, the decision about who gets it, people, frontline workers, particularly people with comorbidities or whatever, all that has to still be decided. But by the end of the year is one idea, that we will have a certain number of U.S. citizens vaccinated. I know in China, they've vaccinated many of their military individuals, but that age group, and I'm not sure how much we're going to learn, but that age group and the gender and whatever, and the homogeneous nature of the genetics, I'm not absolutely certain what we're going to necessarily learn from that work, but it still will be accomplished, and we definitely will learn something.
So one last question came in, if you still have time. Curious about the differences over time and how long it takes to get a vaccine. I'm interpreting this question, and please, Antonia, if you'd like to unmute yourself and ask the question if I get my interpretation wrong. My interpretation is, how is this moving so rapidly when so many vaccines have taken years to develop? How are we able to get this so quickly? But Antonia, if I am interpreting that wrong, please feel free to unmute.
Okay, so this is a very good question, and causes some fear, right? Because we have political considerations, we have all these other things, but we also have very good science that has developed now, that has prepared us for some of these ideas. They've been around in theory for some time, and now we're able to have money. By the way, I mean, here's one of the differences. The money that was involved in some of those, there was very little money for the papillomavirus vaccine ideas at first, but there's essentially billions of dollars available. And so I don't want to say that it's just totally dependent on that, but on 2 counts, we've had huge amount of money available, and also theoretical and practical ideas that have accumulated in our knowledge. Remember, Jenner, okay, vaccinated against smallpox without knowing what a virus was. Okay, and so just observations of what it took to protect individuals from infection were sufficient to actually come up with the vaccination protocol that basically eliminated smallpox. And similarly with poliovirus, we obviously knew a lot more, but we didn't know really how this virus, how this vaccine necessarily worked. But that's what part of when you have phase 1 and 2 that show that it's safe, phase 3 shows that it works, and then, to be honest with you, many times after, we have to figure out how does it work, and that sometimes occurs after we've shown that it does work. So by safety and efficacy, we talk about safety. We have large-scale studies that show that when I'm injecting something in healthy, here's part of the problem with vaccines. I also work in chemoprevention. Part of the problem is that you're taking healthy people. It's not sick people that Dr. File has to deal with and giving them a drug to help save them. This is healthy people that are very well operating in the world. And now you're going to give them something that, in my case, in the chemoprevention world, is supposedly ward off cancer, but in the case of a vaccine, ward off virus infection. So this is a higher I hate to say this, but in a certain sense, but this is a higher or different standard of a safety necessary when you have somebody that's dying from cancer, for example, and you're desperately trying to save them. And so that's why we have these, we should demand high levels of safety. But efficacy, sometimes we don't necessarily know exactly how these things work, but as long as we show that they do work, efficacy can be, shown by the numbers. Okay, I've warded off virus infection in these thousands of individuals, and they're all safe, and they're not going to show up in the hospital, and Dr. File is not going to have to take care of them.
Yeah, the only thing I'll add, with this Operation Warp Speed, you have to remember that we've got new technology. I mean, this mRNA technology, I think, is relatively new, but but secondly, there's already been vaccines for these other coronaviruses, SARS and MERS, actually. And so we had the experience of those that could be tailored onto this to allow it to be so rapid in its development.
So another question has come in. Given the immaturity of ACE receptors for kids under 10, should states be changing their guidance for preschools and childcare settings? So instead of cutting the classes in half, should they be re-expanding if the age groups are 10 and under? Or are there other reasons to be concerned about those age groups?
Gosh, that's a good question. I think, there's so many different approaches now to restarting schools that we're going to find out in a month or two what is the best way. And when I said that one of the reasons why the kids under 10, that's sort of a hypothetical situation. I can't tell you exactly why the kids under 10 seem to be less likely to be as sick or transmissible, because there are studies to show that you can actually identify high levels of virus in even younger children as well. I mean, and there's certainly been outbreaks in daycare centers. And so there's still a lot of unknowns about the whole concept of transmission and age and et cetera. And, as I said, I think that what's going to happen, we're going to have these observational sort of experiments by how different schools make their plans to reopen, that will find out what is best in the future.
Yeah, I concur. The other consideration, though, is the age of the staff, the teachers, the people, the janitors, all those people associated with the process, the structure, and then of course bringing back home various things. So, Dr. File is correct. We definitely need to show how infectious these individuals are. Can they in fact pass it off to teachers and or elderly at home, for example? And those I don't think we have. I haven't seen very good data in regard to that yet, although there is a experiment going on in Cleveland that is looking at people infected very early on and trying to track what's happening in the house from earliest point of infection, and then what's happening to the rest of the people in the house. And so there, but again, that's just started. That project has just started.
So there are no other questions in the chat box. I'll give people one last shot at a question if they'd like to unmute or chat, but I'm letting everybody know that on December 2nd, we're going to have another one of these sessions, but focused on the coping and mental health aspects of this, really looking at building resiliency as we head into 2020. We'll have Stephanie Orwick from NEOMED's Counseling Center is going to be presenting, and we'll have a panel of folks. So we hope that everyone is going to join us again on December 2nd. And thank you so much, Dr. File and Dr. DeLucia, for all of this information and for your patience with the questions and continuing to bring us your expertise, from right here in Northeast Ohio.
Okay, stay safe, wear your mask.
Yeah, thank you, and good luck to all. Okay, particularly with vaccine education. Okay, so again, thank you all.
Thank you.
Okay, bye, Nicole. Thank you.
Bye. Thanks.